So you mentioned pharmacological help, and I want to talk about other aspects of help and all the different facets of help because we've talked about family as being able to recognize perhaps that somebody's not doing so well in terms of their mental health. We've talked about the individual themselves being able to recognize that. And for the individual themselves, moving on now to talk about the positive things that they could do to protect their health rather, to maybe seek help if that's not sufficient, if all the other factors that they've tried to introduce are not sufficient, how they would seek help. Let's start with the individual. What sort of advice would you have? I know for myself, it's January. I try and make my resolutions, and maybe, like other people, the resolutions don't always happen, or don't always continue to happen. So, what advice would you give? Let's say I'm struggling with food. I'm living with diabetes. I really want to make this change, and I come to you, Dr. Piri, and I say, how would you how would you suggest I can make this change and keep this change going past January?
So, I guess, obviously, a lot of times people come to us when things are probably have gone out. But I think what's been happening most recently, with the awareness of type one, type two, and is that there's a need to help identify people quite early. And I know a lot of primary care services now are offering diabetes educational programs, so that people can either go there and learn about uh, diets, but also some ways of managing just really basic dietary needs, but also looking at how they can implement those changes in their everyday lives. So there are those things. Obviously, there's the programs like the Diamond uh, uh, program. Even if it's a 1 day program, some of those programs are really quite helpful. But we also have to acknowledge some of the challenges for people that might also be taking medication as well, because this is where the battle really with overweight, with obesity, um, from medication, which might then affect their mental health well-being in terms of they might not feel motivated to get up and go and exercise and go and do those things. So a lot of times then people come with depression, and lack of motivation. Obviously, what we then do is, I think, obviously, the psychologically you completed a robust assessment to understand, okay, what medication are they taking, obviously, which then also might require a review with a consultant psychiatrist to ensure that that they are probably taking the best medication, effective, but also with minimal weight gain as well, because that's one of the things. I think it's important to understand the side effects of the medication that you're taking. So that's really very, very important. Then, but also seeking treatments like cognitive therapy, because one of the biggest challenges is that people are not disturbed by thoughts per se, but by the meaning they attach to their thoughts. And this is really, really where changes can come through, is when you change the way you think, when you alter the way you think, it can actually have some really good outcomes. And so identifying all those unhelpful ways of thinking, then we can look at how we can create alternative ways of thinking to then change the behaviors.
So, cognitive behavioral therapy, I think, is what you're explaining to us about there. So, the unhelpful ways of thinking and how you can redress those unhelpful ways of thinking. Would that be correct? Would that be a simplified way to describe it? So, when I think, eating, um, let's say I think eating vegetables is not going to be good or helpful for me in my diabetes, which is an unhelpful way of thinking about the vegetables. It's how you then change me, or I change myself or my thinking to thinking that the vegetables are actually quite a good thing for me and my diabetes. So cognitive behavioral therapy can help with that.
Absolutely. And bear in mind, we all have beliefs, don't we? So from there, what you just done, you just mentioned two types of beliefs. Now, one of the things that I always remind my clients is that, beliefs are not facts. They're just one way of looking at something. A lot of times, we can look at the world as, yeah, if I eat vegetables, this won't help, or if I do that, that won't help. And so what we do in CBT, we can explore both beliefs. So we can test those assumptions. They're assumptions. We all have got assumptions, don't we? So we say, okay. And I think that's very important for clinicians, because in a way, you're not just saying, no, you're wrong. This is what we do, because then you're pushing that person away. So what we do in CBT, we say, well, let's look at them this way. Let's take that one assumption or that one belief as let's say hypothesis A, or one way of thinking, part A. Then we will look at a psychological way of addressing that as hypothesis B, or an approach B to look at this. And between the two of us, we'll try and test these two ways of thinking and see which one of them stands or is better. And then so you engage the person and say, are you willing to do that? So for instance, then we can take that belief. So for instance, I can take the belief about eating vegetables and say, so John, how strongly do you believe that is true? And so you might say, well, I believe 100% that eating vegetables is not healthy for me. It's not good for me. It's not going to help me. Okay, so we can take that belief and rate the intensity of the belief, because that's another thing that is important. We look at we want to explore the beliefs that are strong. So what then we do in CBT, we look at, okay, so let's take that belief that you have about your food, about your greens, about your fiber and all those things, and look at the evidence that supports your belief, which is what tends to fit in with their prejudice. But then also, and this is where people have got a deficit, is that because oftentimes they neglect the evidence that does not support their belief. Now, what we will do there is we will help them to identify that evidence and bring it to the foreplay. So in a way now, they can look at, well, there is the evidence that supports my belief. There is the evidence that does not support my belief. Now, can I look at those clearly and then look at which one outweighs the other, and then make an informed choice or decision, not based on assumptions, but based on facts. The other thing that we agree on beforehand is the definition of effect. So I tend to use this thing that is something that will stand in the court of law. It's not what I feel or think, it's something that will stand in the court of law, and that then allows us to really bring it down to something that's clear and they can understand. And I said that's just one example that you can use to challenge those unhelpful thought beliefs.
So that's a great illustration of how CBT can help somebody change their beliefs, their own prejudices, and therefore consequently their behaviour as well. So thanks very much for that. And the other thing that I remember hearing about, not necessarily with CBT, but if you want to change something in terms of behaviour, about habit forming, that you tie it in with something that you do on a regular basis. So if I use a silly example at the moment, I'm trying to make sure I take some cod liver oil on a regular basis. Now, cod liver oil is not a pleasant thing to take, but what I've found to enable me to develop that habit is if I take the cod liver oil immediately before I have my first cup of coffee, then I can make sure I pretty much take the cod liver oil. So a way of forming a habit is to tie it in with something that you're doing already. Would you?
Absolutely. I mean, I'll give you a good example, where religion plays a key role. So, as I said, most of our communities are very religious. You know, whether it's being a Christian or whether it's someone is Islamic or whatever faith. Now, one of the things that I found really interesting was someone saying, well, they pray three times a day. And for them, associating an action like taking their medication at the same time as their prayers, that was one of the key things that actually helped someone actually begin to adhere to taking their medication. Because just like you're saying, you're associating with something that's really, really important. For them, they will take their medication when start their prayers, and then using their prayers during the day. And that really helped them to remember, but also it became something that fell within that routine, that they were doing. And I think people can find different things like that within some of their practice. So you're not trying to change things so much. You're working with what you've got and making it easy for you.
Absolutely, because I can share with you that my other New Year's resolution to do some regular strengthening exercises hasn't happened because I haven't tied that into a habit that I'm doing already. So I mean, it's really helpful to be able to recognize certain things within ourselves that might identify to us that we're not doing so well, either with our diabetes and or with our mental health, because the two things obviously, as with everything, are interconnected. And it's really helpful to us, Dr. Peary. Thank you for the advice that you've given us and the information that you've given us about services like cognitive behavioral therapy. And people would recognize that by people sometimes calling that CBT. And also, with a more serious and severe side of mental ill health, how that can impact on well-being, physical well-being, diabetes well-being, and your general well-being. So thank you very much for that. Was there any lasting tips that you wanted to give us?
With dietitians play a key role as well, ensuring that people with mental health problems are referred to dietitians to help them with that as well, but also access to cognitive therapy. I think one of the most interesting things in terms of mental health and diabetes is that we've got the IAPT services. In the UK, we've got centers all over the country, and what's been really, really encouraging is that there has been an increase and uptake of psychological interventions from Black communities, South Asian communities, and that's actually increasing. Part of this is due to people are able to self-refer, which means they can also pick up the terms that they are seeing as well. So I think there is progress, but there's also quite a lot that we might need to do in order to ensure that the needs of the communities that we serve, especially the racially minoritized communities, are understood and also are addressed as well. But also, we also need to teach our clinicians to be culturally sensitive, to be culturally competent. When they're conducting their assessments, they are able to understand the needs of these communities. Psychoeducation for communities about, I mean, a lot of things are to do with the illiteracy. Some of our communities might not know about these problems until it's too late. But if psychoeducation is taken to communities, meeting people where they are at, whether it's church communities or whether it's local communities, and teaching them about diabetes, and teaching them about some of the symptoms which might not be identified, because a lot of times, I guess, interestingly, when I searched to find out what culturally sensitive tools and resources are there for people from African and Caribbean communities in relation to diabetes, there is very, very limited, up to none, except for things for language. Now, that I think is an area that of need that we need to change. We need to really make sure that we do more to create resources that are culturally sensitive. It's not just about language. It's about looking at what are other interventions which might be effective for this group which are not being used. So that's another area that we need. The other area, I mean, as a researcher, I would think the other area is really to encourage our community to take part in clinical research. Because, as we always said in our Black communities, nothing about us without us is worth the paper that it is written on. The problem is, how can we have interventions if our communities don't take part in research? Because then research becomes of the other. So the other will get the best interventions that actually are effective for them. But guess what? They might not be effective for patients because they're not also taking part in the study as well.
That's I think a fantastic thought to leave us with, and something that is a challenge really to the community. How can we have culturally sensitive treatments, pathways, whatever aspect you'd like to look at, if we're not involved in forming those pathways? And part of that may be in terms of research. So thank you very much, Dr. Peary. Really appreciate it. And yes, we look forward to lots and lots of questions now. Thank you.
Thank you.
Thank you.